Hello, everybody. Welcome, welcome. We're back in business and it's a new year. So we're glad you joined us. Lots of good, familiar names and faces. If you can share, share your faces. Hi, Jeff. Good to see you. And Shirley, great to see you back. Hope everything's good. Dan Saltman, haven't seen you for a while. Hey, great. Okay, why don't we go ahead and get started? Okay, so welcome. So we just want to start off with a few introductory and housekeeping remarks. This is a CMA activity that's jointly provided by the Queens Medical Center and UH Jabson Department of Geriatric Medicine. We have, we've switched our CME provider, and so next slide, yeah. I think, and also this is this is also a reminder to complete an evaluation form. So at this time, enter your name and your credentials of everyone viewing the geriatric echo for CME attendance purposes. And as a reminder, evaluations are required for CMEs, and you can find the evaluations by following the link in the chat box at any time on our or go to our website and or email advertisement. Your comments are very important to the planning committee and will be used to plan future meetings. Okay, and a little bit about ECHO here. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each one of us right here on the front lines. And as the ECHO motto goes, all teach, all learn. So it will take all of you to create this community of learning. A little bit about the format. After a short lecture from one of our experts, we will share expertise from the rest of the team and then open up for a time of case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to today's lecture. Our interdisciplinary team here as well, and we are willing to share and teach our collective wisdom with you. So with that, I'm just going to have our team say hi. We have Mary Gotham here, and she's a retired nurse. And we have Sarah Tompkison.
Good morning or good afternoon.
Yeah, our social worker, Chet Kawakami from UH Hilo Pharmacy, and Lucas Morgan, psychologist, clinical psychologist. Yeah, and so when we share cases, we ask that you keep it all HIPAA compliant for our discussion. Okay, so I'm going to introduce our speaker for today is Dr. Angela Lowe, who she completed her internal medicine residency at Stony Brook University Medical Center in Long Island, New York, and is currently doing a second year of geriatric fellowship. In addition to the JABSOM Office of Medical Education Fellowship at the Medical Education in Medical Education. And next fall, she plans to be a clinical assistant professor of medicine at Stony Brook, serving as a full-time resident preceptor at the resident primary care continuity clinic. And so she'll be doing a lot of teaching, and she's going to get us started today with a topic about falls. So without further ado, I welcome Angela Lowe, Dr. Angela Lowe. Go ahead.
Thanks so much, Dr. Wen. Thank you, everyone, for having me today. And so I will be presenting about falls prevention and management. Today's objectives include to be able to define what a fall is, to identify different age-related changes, chronic conditions that may increase fall risk, to be familiar with different fall screening tools, and to be able to recommend different fall prevention strategies to patients and caregivers. But first, what is a fall? So a fall is an event that results in a person coming to rest inadvertently on the ground, floor, or other lower level without known loss of consciousness. Unfortunately, every second of every day, an older adult in the US will fall. Per one CDC report, 1 of 3 adults 65 or older falls each year. Complications resulting from falls are the leading cause of death from injury in adults 65 or older. Falls are associated with subsequent declines in functional status, an increased likelihood of nursing home placement, and an increased use of medical services and development of a fear of falling. In 2015, the total medical costs for fall-related injuries totaled more than $50 billion. And indirect costs from fall-related injuries impact the quality of life on our patients and also cause an increased use of caregiver support. There are several risk factors that have been consistently associated with falls in multiple prospective cohort studies. These include older age, cognitive impairment, female gender, a past fall history, arthritis, foot disorders, balance problems, low vitamin D levels, use of psychotropic medications, pain, Parkinson's disease, and stroke. Falls are multifactorial in nature. So I wanted to discuss some age-related changes that can contribute to fall risk. These include declines in visual, proprioceptive, and vestibular systems, as well as other CNS changes. So in our visual system, we see decreases in visual acuity, depth perception, contrast sensitivity, and dark adaptation, so thus increasing risk for falls. In our proprioceptive system, we might see some sensitivity, loss in legs. In our vestibular system, you'll see a loss of labyrinthine hair cells, vestibular ganglion cells, and nerve fibers. And so with these changes, balance and equilibrium are negatively affected. Within the basal ganglia, you'll see decreases in neurons, dendrites, and neurotransmitters, and thus this affects postural control. And in our musculoskeletal systems, as we get older, there are also changes in the distal versus proximal muscle activation order, the onset of muscle activation, and the contraction of antagonistic muscles. And these changes cause a delayed ability to maintain postural stability and the ability to maintain an upright posture. And then in our cardiovascular system, we'll see compromises in the baroreflex sensitivity, our resting cerebral perfusion, and total body water. And so these can increase the risk for hypotension, orthostatic hypotension, and ultimately falls. So these age-related changes, they all affect postural control. In addition to them, we also have age-related chronic conditions, in particular Parkinson's disease, stroke, osteoarthritis, and chronic pain. In Parkinson's disease, you might see like muscle rigidity or freezing episodes and bradykinesia, possibly hypotension as a result from the medications for Parkinson's, as well as cognitive impairments. For our stroke patients, they might have visual spatial defects and impaired peripheral sensation, muscle weakness, cerebellar dysfunction, as well as residual dizziness. In patients with osteoarthritis, they might have affected mobility depending on where the affected joints are, and impaired ability to step over objects and maneuver around them, and an affected balance due to avoiding complete weight bearing on a painful joint. Similarly, along those lines, for patients with chronic pain, we might see changes in gait or changes in muscle strength because of disuse. And as well, pain acts as a cognitive distractor. So that's a high fall risk. And then because of the pain, they might take medications that are high risk and may contribute to falls as well. So here I've listed many drug classes that can contribute to falls. Unfortunately, older adults are particularly vulnerable to falls after a new med is started or after a med dose is increased. Increased risk of falling also has been seen after starting or increasing the dose of a non-SSRI antidepressant, benzo, antihypertensive, or diuretic medication. So it's really important to discuss with older patients and their caregivers about the increased risk of falls after a new prescription is done to try to avoid injury. So what are the clinical guidelines out there? The CDC did create an algorithm for falls risk and assessment and interventions. This was validated in 2017 in the National Health and Aging Trends Study. Here they saw that participants classified as having moderate and high fall risk had about a 2.6 and 4.8 times greater odds of falling than those classified as low risk, respectively, controlling for other risk factors. So I just wanted to include example of the brochure from the CDC regarding falls prevention. On the back of this brochure, they actually have a questionnaire of 12 questions. And so it asks about whether or not the patient has fallen the past year, whether or not they've been advised to use a cane or walker to get around safely, or if they felt unsteady when walking. And so after the patient answers these questions, you can add up the points up to a total of 14. And if they did score a score of 4 points or more, then they are at risk for falls. So this is the algorithm that the CDC had revised since 2017. And I will break it down so it's a little bit easier to see and understand. So you start first at the top, where you screen for fall risk. Ideally, that's yearly or anytime a patient presents with an acute fall. So you can use that fall risk screening tool that I had mentioned before. And if they scored 4 or more, that is a positive screening for falls. Or if you don't have that, you can also do these 3 key questions. And if they say yes to any of these, that is also a positive risk for falls. These questions include, do they feel unsteady when standing or walking? Do they worry about falling, or have they fallen in the past year? And if they do say yes to the fallen in the past year question, you want to kind of delve in more, asking how many times or were they injured? For patients who don't screen at risk for falls, it's still good to talk about fall prevention in your visits. You want to prevent it as time goes on. And so you want to include patient education on fall prevention. You want to assess their vitamin D intake. And if it's deficient, maybe recommend vitamin D supplements. And then you want to also refer to any community exercise programs or fall prevention program. And then you want to reassess yearly or any time a patient presents with an acute fall. If they do happen to screen at risk, then you want to start assessing any modifiable risk factors and their fall history. So this includes looking into their gait, strength, and balance. I'll talk about this a little bit more later on, but some common assessments include the time to get up and go test, the 30-second chair stand test, a 4-stage balance test. Like we mentioned before, check for any medications that increase fall risk. You want to look at the Beers criteria. Ask about potential home hazards. Like, do they have throw rugs or slippery tub floor? And if possible, also check for orthostatic blood pressure. If you can, check visual acuity. You can also assess their feet or footwear, assess their vitamin D intake, and identify comorbidities such as depression or osteoporosis. So once you identify different fall risks, you can start, intervening and managing them. So if you find out that they have poor gait, strength, and balance, you can refer them for physical therapy or an evidence-based exercise or fall prevention program such as Tai Chi. If you find that there are risky medications, you want to try to optimize them. If there are home hazards that are likely, you can also refer them to occupational therapy who can do a home safety evaluation. And if there's orthostatic hypotension, you can also adjust medications as you can. In orthostatic hypotension, you also want to educate about the importance of exercises such as the foot or ankle pumps before they stand up. Establish an appropriate blood pressure goal, talk about hydration, and also consider compression stockings. If there's visual impairment, you want to make sure that they're keeping up with their eye doctor appointments, looking into meds that can impact vision, such as anticholinergic medications, talk about cataract surgery if that's been an issue in the past, and then also talk about depth perception and concern for impaired ability to see contrasts when they have multifocal lenses. And then you also want to check their feet wear, right, and then provide education about them, which I'll talk about a little bit more later. talk about vitamin D supplementation if required, and then also just optimize their management of their comorbidities. Okay, so on to the history and physical. So for those at the office not seen specifically for a fall, it's still important to screen for falls. It can be pretty quick. You can ask them, has there been a previous fall? Since a previous fall is a strong risk factor for future falls. You can ask about the circumstances of that fall and also evaluate for gait and balance problems. For those patients who do present because of a fall, you want to get a little bit more history. What were they doing at the time of the fall? What were some modifiable risk factors? Maybe you can address there. Were there previous falls? Is there a pattern to this? Were they having prodromal symptoms? Is there a medical condition underlying all this? Is there a medication history? Is there a change in the medications, a new medication or increase in dosing? And then how about the time and location? Was it really dark? Was it in the middle of the night? And also environmental factors, any objects that might be causing a trip hazard in their home. And I just want to quickly go over the footwear also that are ideal for fall prevention. So you would like to have a white toe box for balance, and then a thin firm midsole as well for supports. Ideally a low heel height, not something too high, as well as a beveled heel. You'd like a supported heel collar and a slip resistant sole. And then for those who might have a hard time bending over or tying their shoes, fastening or an easier fastening mechanism would be good as well. All right, and then another portion of the physical exam is the get up and go test. So this is one of the most commonly used tests in gait evaluation. And here the individual stands up from a chair, walks across a room about 3 meters, turns around, walks back, and sits back down without using their arms. So this can check for muscle weakness, balance problems, and gait abnormalities. And if you see them having to use their arms to stand, that could indicate hip extensor weakness. And if they're unable to complete this test within 12 seconds, that does suggest an increased risk of falls. Another advantage of timing this test is that it provides a good quantitative measure of performance over time. So you can possibly do this yearly just to check in on their gait. And then another test you can do is the 4-stage balance test. So you can see here, they'll start with their feet adjacent and then do a semi-tandem stance. Ideally, you would do these 10 seconds at a time. If they're able to do the semi-tandem stance, you can move on to the tandem stance if you feel it's safe. And not necessary, but if you really wanted to see how their balance is and challenge them, you can have them do 1 foot, although it could be a little tricky for that. So if patients are unable to do the semi-tandem test for 10 seconds, they are considered at risk for falling. With regards to lab tests and diagnostic tests, there aren't any standard diagnostic evaluations of a person with a history of falls or high risk of falls. However, you can do some helpful lab tests, including checking the hemoglobin for anemia or maybe a BUN creatinine for dehydration, or checking their glucose concentrations for checking hyperglycemia with hyperosmolar dehydration, which can cause falls. Additional tests can be done, but it really should be driven by what's found in the history and physical. For example, echoes should be reserved for those with cardiac conditions believed to affect blood flow to the brain, or spine radiographs or an MRI can be useful in patients with gait disorders, abnormalities on neurologic exams, like spasticity or hyperreflexia, to exclude things like cervical spondylosis or lumbar stenosis as a cause of falls. Okay, so now I wanted to move on to preventing falls, selected risk factors and suggested interventions, which I did touch briefly upon before. So for those with general risks, suggested interventions include exercise programs with resistance, gait, balance, and coordination training, education and information, cognitive behavioral intervention to decrease fear of falling and activity avoidance, And also daily supplementation of vitamin D3 if they have vitamin D deficiency, and possibly those in long-term care facilities. For those with medication-related factors, such as those using benzodiazepines, sedative hypnotics like Ambien, antidepressants, antipsychotics, and antihypertensive medications, it would be really good to consider whether or not that medication is really needed, and maybe reduce the dosage if possible. In addition, if they're taking sedative hypnotics, it would be good to address sleep problems with non-pharmacologic interventions, advising on a good sleep hygiene. And then if they do have to take these risky medications, we recommend educating the patients on the appropriate use of medications and monitoring for any adverse events. If a patient has had a recent change in dosage or their number of prescriptions, or they have polypharmacy with 4 or more prescriptions, or they use other meds associated with fall risk, same thing, you want to review the medication list and reduce the number and dose of medications if possible. You want to counsel patients at risk for falls because of a new prescription or dose increase. And then you want to monitor the response to any medication changes, because perhaps they don't really experience any changes and maybe they don't need the medication. And then with regards to mobility related factors, so if there's concern for presence of environmental hazards, you want to look into improving lighting in their homes, especially at the nighttime. You want to remove floor hazards like a throw rug. And then you would like to also recommend replacing or maybe fixing existing furniture with safer furniture, making sure they have the correct height, maybe of chairs, making sure that their legs are stable. In addition, if required or recommended, they can install support structures, especially in the bathroom, such as railings, grab bars, elevated toilet seats, and then also using non-slip bath mats. With regards to mobility-related factors, if you find that the patient has impaired strength, gait, balance, or transfer skills, you can refer them to physical therapy for a comprehensive evaluation, rehab, and training in use of assistive devices. We'd like them to have gait training, prescribed balance and strengthening exercises. And then if they're able to perform a tandem stance, it would be good to refer them to doing Tai Chi, dance, or yoga. I believe here in Honolulu too, there is a gentler, less intensive form of Tai Chi as well. So maybe if they can't do the tandem stance, they could still avail of resources here. And then you can also provide training in the patient and their caregiver in transfer skills, prescribe appropriate assistive devices, and then recommend appropriate footwear. If they have impaired leg or arm strength or impaired range of motion or proprioception, strength exercises are really important, including resistance training 2 to 3 times a week, Tai Chi, as we mentioned before, and also a referral to physical therapy or occupational therapy would be beneficial as well. And then those with medical factors such as Parkinson's disease, osteoarthritis, depression, impaired cognition, or carotid sinus hypersensitivity, or other conditions associated with increased falls. Again, you want to optimize their medical therapy, monitor for disease progression and any impact on their mobility and impairments, and then determine the need for any assistive devices. If they're having to use their restroom multiple times at night for frequent nighttime urination, it's advisable to use a bedside commode to limit the distance that they have to go. And then for those with carotid sinus hypersensitivity, if they experience falls due to syncope, it's advisable to have them see the cardiologist for possibly cardiac pacing. And then postural hypotension it's a big one for fall risk. So here you really want to review medications and adjust dosing or switch doses to less hypotensive agents. If possible, you'd want to avoid vasodilators and diuretics. And patients with hypertension, intensive blood pressure lowering treatment does decrease the risk of orthostatic hypotension to decrease that gap between the hypertension level and the orthostatic hypotension level. And then you also want to educate the patients on activities to decrease the effect of postural hypotension, such as slow rising, ankle pumps, hand clenching, elevating their head of bed, and then slow rising from recumbent or seated position, and then possibly having them get grab bars by the toilet and bath. And you also want to optimize their hydration. In addition, you can think about compression stockings to help. If their blood pressures are not too high, you can think about liberalizing their salt intake. For appropriate patients, you can also recommend trying caffeinated coffee or caffeine with meals for those with postprandial hypotension. And then you can consider additional meds if their hypertension, heart failure, or hypokalemia is not serious. And those meds include midodrine or fludrocortisone. So for midodrine, you can prescribe from 2.5 to 10 milligrams 3 times a day, 4 hours apart. Fludrocortisone, you could do 0.1 milligrams Q8 or 24 hours. However, you do want to try to have this done during the daytime for ambulatory patients, because if they're lying down or especially at night, they could experience pretty high blood pressures. So it's important to monitor their blood pressures when you do have them on this regimen. And then another medical factor includes visual impairments. Like mentioned before, cataract removal is beneficial. I actually saw that the first, but not the second cataract removal is found to reduce falls. However, the second cataract removal is still useful for improving one's vision. And then also you just really want to increase awareness and vigilance when someone's wearing multifocal lenses while walking, especially up or down the stairs, since multifocal lenses can decrease depth perception and contrast sensitivity. All right, so considerations for recurrent fallers. There will be patients who will unfortunately fall repeatedly despite many interventions. They generally had non-modifiable risk factors that place them at quite high risk, such as Parkinson's disease and dementia. And so for these patients, it's really important to reduce modifiable risk factors, like reducing meds associated with falls, treating pain, and assessing environmental hazards. And as with all patients with history of falls, it's also important to get a history of the events surrounding the fall to exclude syncope, seizures, and other less common med conditions. These patients frequently require medical attention because of the falls, and they're often given the suggestion to move to a nursing home or an environment with more intense supervision. So patients who are able to understand their risks and alternatives and express their choice to remain independent do have the right to do so. So in these instances, it's really helpful to do a direct discussion of goals of care. In addition, there are various home safety products such as push button alarms and emergency activation devices. Some families also install cameras to just check in on their loved ones. So we can have these be used by patients to avoid a long fly in case they do fall. So some key points, falls are common events that also threaten the independence of older adults. Falls are usually multifactorial in origin. Older adults who have had even a single fall should have a gait and balance evaluation. And effective interventions include bed review, exercise programs with muscle strengthening and balance training, use of appropriate footwear, multifactorial interventions like home assessment and vitamin D supplementation for those with vitamin D deficiency, and possibly for those who are institutionalized. But that's my presentation on falls management. Thank you so much for listening in. Does anyone have any questions?
While you guys are thinking about questions and cases, I actually wanted to invite Sarah Tompkison to talk a little bit about, she actually does Tai Chi, right? And she knows about some of the community resources for falls prevention. So maybe you could share a little bit about that, Sarah.
Yes. Last year, the city and county, the Area Agency on Aging, was able to get a grant that allowed all the local YMCAs here in Honolulu to offer to anyone over the age of 65 Tai Chi and also congregate meals. I just heard that in January of this year, they were able, the Elderly Affairs Division, to get an extension. So if you have clients that are interested in Tai Chi, I put the link in because they have a list in the link about falls prevention of all the certified Tai Chi instructors and where the classes are being held. And a lot of what the Tai Chi instructors are doing, including myself, is we're trying to incorporate something called Qigong, which means deep breathing exercise. And so with the breathing is so important, even when you're walking. And believe it or not, sometimes we tend to hold our breath when we do move. So it's kind of retraining the brain to look at that. I'm so glad, Dr. Loh, that you talked about not just the external factors that contribute to falls, like things within the environment, but there's some intrinsic factors as well. And that is when people sometimes have had falls, it does affect their mood. And I've seen that people not only get depressed, but they get anxious. And I'm hoping Lucas can join in with me on this, but along that line, they're less apt to participate in social activities and they isolate. That's also, there's a lot of psychosocial factors that impact falls as well. I know, Lucas?
Want to talk about fear of falls? How to overcome that?
Yeah, that's a great, super important topic. And you mentioned that, Dr. Loh, as something that happens and can become, sort of a pervasive, like limiting factor for someone who's had falls. And so that fear of falling can become limiting. And that's tricky because on the one hand, it makes all the sense in the world that a person becomes terrified of falling again because they've just spent a week in the hospital and, a month in the rehab center and they don't want to go through that again. So it's understandable that part of their brain is like saying, be careful. You don't want that to happen again. And yet, that sort of increased narrowing of their perceived abilities can become mood degrading. So, sort of a combination of compassionate encouragement, problem solving, and getting folks to push their comfort zone a little bit, sort of in a gradual way, can be helpful. Also encouraging folks to use assistive devices, even though you think maybe they don't need it right now, just to get them trying things again, because the more they try and can be successful at, the more they'll challenge some of those fears. So really important point. So thank you.
Great. I have a question here. Review the likelihood of forward versus backward falls and the difference in causes. Want to tackle that, Angela?
Yeah, that's a good question. So I know patients, especially those with Parkinson's disease who are more with bradykinesia and freezing episodes, they have a greater likelihood of falling backwards. And so really choosing the appropriate assistive walking device is really important for them. Because if you use the wrong one, such as those without like maybe a lock on it, they have a greater likelihood of falling backwards. In terms of falling forwards, that's, I believe, the more common one, and that's really multifactorial, depending on the medical conditions. Is it hypotension causing it? But those usually are the forward falls.
I was just going to add there is this wonderful technology that we have nowadays where, and I thought it was Ho'okele, but there are some companies that actually have devices that you can place on yourself so they can actually anticipate a person falling. And there's also alert alarm, life alert, or the alarm systems you can also put on your body if you've had a fall. I think that's kind of helpful too, because especially if you're living alone and you can't get to the phone or someplace, at least you can hit the button, the pendant, or whatever and now we have iWatches. Do you know when I'm exercising and if I exercise too hard, this really irritates me, I get a message, are you okay? Have you fallen?
That's true. They're getting too sophisticated, these watches. Now, Alice Liu asks, is the definition of fall stated in your lecture the same definition used for the state and national reporting at long-term care?
So I looked up the CMS definition because I believe that's the one that's used for state and national reporting. The one in my PowerPoint was based on AGS, the American Geriatric Society. But for CMS, it's slightly different. I can also copy it into the chat here so you can see it yourself. But it's also still a fall of intentionally coming to rest on the ground floor or other lower level, but it's not a result of an overwhelming external force, such as a resident pushing another resident. So an episode where a resident lost his or her balance and would have fallen, if not for staff intervention, is considered a fall.
Great, thank you. Dr. Saltman, you have a question?
Greetings. Thank you, Dr. Lowe. That was great. Well, I have a bunch of questions, of course, but and a comment. So the comment I think is important for that I learned with taking care of my own parents, and that is an OT referral by a physician can result in somebody who really has a lot of skill at home assessment, and they come into the home and they can look at the grab bars and look at the rugs and look at the stuff. So it's hard to get a home assessment, generally speaking, for a lot of people. So an OT referral is really, I found to be remarkably useful and effective as a means for sort of triggering that process, maybe even where insurance helps pay for the grab bars and the assistive devices and stuff in the home. So that's really a good tip, I think, for clinicians to understand. So that was a comment. And then, so I have a few questions. One, right at the very beginning, you said that women had an increased risk for falls. I was wondering if you had an idea why that was. And if you want me to ask all the questions at once and then you can answer them all at once, that might be easier for you, really. Or however you want to do it.
Either way, to be honest, I actually am not quite sure why women do have a higher risk factor for falls compared to men. I don't know if it's because they also just have a higher risk for osteopenia and osteoporosis. And that also is in association with more muscle weakness. Dr. Wen, have you heard of any reason?
No, not particularly, although I know Sarah mentioned something about osteoporosis. That just makes the fall more dangerous. So just being more careful about that.
And then my next question was about vitamin D testing. It's kind of fraught with problems. They say that serum vitamin D is not necessarily a good reflection of the actual levels. Would you, and I appreciated that you said that to consider it for anybody in long-term care facilities. I think that might be, that might be as good as anything. You add a sort of fixed dose, your kind of standard dose of vitamin D to everybody who's in a long-term care facility. They're not seeing that much sun, but even in Hawaii, I mean, my experience in Hawaii has been, plenty of sun, so it's not a sun issue. You do the test, it's low, you give supplementation, it stays low. It doesn't seem to really reflect the actual stores necessarily. So it's a tricky business. So comments on vitamin D testing was what I was asking.
Yeah, I think there's still not no set consensus on vitamin D testing. And then in addition, so a lot of my, the information I got was from our AGS textbook. And actually they did recommend just flatly to do vitamin D supplementation for long-term care residents. But when I was looking at what's out there, the studies, they're still kind of fraught with conflicting data. And so I know one of the reasons why we don't really jump on the boat to give vitamin D to our residents in the long-term care facilities is that it just adds to polypharmacy as well. And many times, they're losing weight, they don't have great appetite. So sometimes we look at the risks and benefits and we see maybe we'll just hold off on adding that extra pill.
And typically there's vitamin D and multivitamins as well. So there's a little bit of vitamin D supplementation. It's like, I don't know, 25 mics or something usually, pretty low. But and then go ahead.
Was there any comments from you, Chad, about vitamin D?
No, I totally agree. I think that, you have to look at it in the context of like the overall picture. And yeah, it certainly is one more medication that the patient has to take. And so I definitely agree.
And then my last question was, I know that there's a body of literature that supports Tai Chi as an intervention for fall prevention. And I also have practiced Tai Chi and Qigong for 45 years kind of thing. Thank you, Sarah. So my question was, you sort of talked about other exercises or other sort of exercise modalities that could be interventional in fall prevention. Is there a body of literature that supports that over Tai Chi? Because I've never seen it. In fact, the Tai Chi studies are often kind of they're like strength training or usual, sort of regular exercise or some kind of routine exercise or strength training versus Tai Chi, and Tai Chi is the superior modality. So I was wondering if you found anything. Is there literature that supports other physical activity interventions for fall prevention?
You're right. I haven't either seen any other particular exercises besides Tai Chi. But I do know in the community that there are fall exercise programs, especially in the VA. I'm blanking on the name of that program right now, but they incorporate also Tai Chi in that program.
Very good. Thank you. Very good.
Yeah. And thanks, Renata, for your comments about GI absorption and the problems with that as you get older as well. That's true as well. There's a few comments about hula in there because that's going on here. I don't think people know about the fall thing. I hope somebody does do that follow-up study and even adds that on evaluation piece on. That would be fantastic to know about, making Hawaii unique. I know Mary had wanted to say something, and so did Rita Bell. So maybe go ahead, Mary.
I just, when Dr. Salzman talked about the referral for the OT to do the home safety assessment, I've been retired 3 years, so I'm not quite sure what public health nurses do now, but one of our major assessments was fall risk and intervention. And at the time that I left, we were using a Missouri home assessment, had 10 items that were covered by Dr. Lowe today that we looked at, and if we could modify them, we intervene. And so that just putting in a plug for PHN that they really focus on fall prevention and intervention. So don't have to worry about trying to get insurance to cover it for that.
Great. And I know Chad Cambra said something about having neighbors, right? Check in, and also post office does that as well. If they don't see you picking up the mail, they're going to actually do a check on you as well. So that, yeah. And then of course there's all those Ring cameras, right? All kinds of cameras that now help supervise or from afar. Yeah. Rita Bell, did you have a comment?
Yeah, I was going to add about the getting home physical therapy or home occupational therapy. Medicare's definition is very generous. You have to be homebound, and homebound is simply hard to leave the home. It is a very generous definition. You can go to church on Sunday, you can go to dialysis and still be considered homebound. So I always try my best to order home OT or home PD. Thank you.
Right. Yeah. Yeah. For some reason, some doctors don't order a lot of that. And I kind of wonder why. It's not that hard to do. And it
PT will not do that assessment though. They will not go rummage into your bathroom and figure out if you need grab bars or not. They typically don't do that. They blow in, they do their thing, they blow out, they're not doing a home assessment typically in PT.
It's OT.
It's
Yeah.
OT.
Yeah. Lucas. Oh, you're mute.
Just wanted to bring up another issue around the family who may live with the older adult person with the fall risk. And sometimes you find family members who are, of course, concerned and become overprotective of their loved one. And so they are really trying to, of course, prevent a fall. And in doing so, there can sometimes be an overprotectiveness that limits what the older adult is allowed to do. And so that can be helpful to have a provider who may have a relationship or cultivate one with the family to help them create more space and manage their own anxieties for the person, to help the older adult have more freedom to do things within safe limits. So it can be challenging.
Great. Yeah. Any cases? Anybody has any challenging cases? Something you've seen? I know, Susan, right?
Yeah.
You mentioned that you had something. Oh, Wi-Fi.
Yes.
Mhm.
Yes. So I saw a gentleman at the VA. He was transferring care over from primary care to geriatrics. And he was kind of an interesting guy because he was falling on a regular basis and didn't have anxiety about it. He was just like, yeah, I fall. Okay, no big deal. It's part of my life. I deal with it. So his story is he was a 78-year-old retired engineer, widowed, no children, living in a condo on his own, and a single floor condo. And he would ride the bus to get to the store and to his appointments. And one of his regular pastimes was to ride the bus down to Waikiki and just kind of walk around the zoo aquarium area and talk to tourists, which, kind of atypical of an engineer, but that's what he enjoyed doing. He would also pop into the ABC store down there in order to pick up his meals and then take them back home. So he was eating mostly pre-prepared packaged foods that he would pick up there. His medical problems included hypertension, which he was on losartan, atrial fibrillation with rapid response, and he was on amiodarone and Eliquis for that. He also had BPH and was on tamsulosin. And he did have osteoporosis, and I know he was on alendronate, but I don't recall if he was on vitamin D or not. So that's one of my lacuna that I just don't remember. His symptoms, he did have urinary frequency and would sometimes dribble on his way to the toilet, but no incontinence, and that had been attributed to his BPH. And he did have this dizziness that had been present for a number of years. And initially, he underwent a workup. He had a CT scan of his brain. He had blood work done. He saw a neurologist, and people were like, yeah, we don't know what it is. You're dizzy. No, live with it. He tried taking meclizine, and between the side effects and the fact that it didn't really help much, he just didn't take it. So he literally was just kind of living with this dizziness that he described as just feeling off balance. And then in the last 8 months, that off balance was getting to the point where he was reaching out for walls and in his home. And so he would, walk down the hall holding onto the wall, and he was starting to fall, which is why he was like, I guess I need a geriatrician now. And that's when he scheduled to see the geriatricians at the VA. No injuries, he would always manage to, just kind of, he was just really good at falling, I guess. And he didn't get injured. And he did start using a cane. He had been given a walker, but did not like using it in the home because, it's just a pain to move around in the home, and then on the bus it was difficult to fold it up and carry it up the bus. So he had a crook neck cane that he used. He was about 6'2". He was a pretty tall guy, and so his cane didn't look like it was tall enough for him. On his exam, his blood pressure was normal, or it was controlled, and his heart rate was controlled. Orthostatics were negative. He did have abrasions and bruises on his forearms and his legs, but nothing that looked infected. He was wearing slippers, flip-flop slippers, and sitting there, he didn't look dizzy. He could hold a conversation with me, and everything was fine. But as soon as he got up and started to walk, he would just kind of lurch to the side and reach out for the wall. So he definitely could not do that tandem stand. I don't even think he could have stood still with his feet together without using the cane. So definitely ataxic and kind of this, truncal instability as he was walking. And so this is what I had to start with. I didn't have any of his cardiology notes. I didn't have any of the prior imaging that had been done. And so, yeah, I'm wondering, how do we help this guy stop thinking that falling is okay? And how do we prevent him from getting hurt?
Wow, good case. Very
Yeah.
complex.
Yes.
Well, I don't know, from my perspective, I think he needs a better neurological workup. And that's what I would start with, including an MRI. He may have some small infarcts that we don't know about, or it may not be obvious without further testing. And sometimes, people have these cerebellar things going on.
Yeah.
Or some, early, Parkinsonian type of, things. I'm not, I think it's just going to need a much more comprehensive. That's what I would start with, neuro workup.
And careful medicine review, or revisiting the medicines is always a good first step as well. And in the physical, is there an alcohol history? That was a question I had about that.
It was a remote history. He had quit drinking, I guess associated with his wife's death. He had been drinking at that time and then realized it was not good for him and stopped. So maybe like 12, 15 years prior, but not currently.
Yeah, you might, that would be worth revisiting too. That's kind of that indifference. That indifference is unusual, I think. And I guess I've seen that mainly with either, sort of some kind of central nervous system thing, or alcoholism, maybe.
Autonomic dysreflexia, right? Yeah, that's what something could be. I was wondering, this case brought up an issue. Like I have tons of people, like they refuse to use canes and walkers, even though highly recommended. Maybe they think it's an ageism thing. How do you how do you get past that, right? Any ideas from?
That's a lot of what sort of the working on these drastic transitions, and using a cane may not seem like a drastic transition when you're trying to have someone else use it. And yet, as a person, your identity as a human who doesn't use a cane to becoming a person who uses a cane can be a very, almost devastating to some people. Like, that was always those people, those old people. And now you're saying I'm one of those people. And so that internalized ageism can be a very significant barrier to explore. And, this guy, in this case, he knows that, I'm assuming he knows that falling is dangerous, and that one of these days, one of these falls could be a lot worse for him. And so instead of, I'm sure, giving him the risks, reading him the risk riot is something that happens initially, and then exploring why he doesn't feel like he has a reason to care if he gets more banged up or if he ends up in the hospital, or because some folks, maybe they're alone, maybe they don't feel like they have much to live for as they are perceiving their own demise or decline, and they just, okay, so what, and meeting them there would be the place to start, I would imagine.
That is great advice. Thank you.
Yeah, in fact, I was thinking that, the diagnosis and the workup is almost academic. For him, what matters to him is that he can go up and down Waikiki and talk to the tourists. Right? So, in some sense, right? It's his psychosocial situation that's going to drive what we can do for him. Any ideas, Sarah?
I was just thinking, what's very interesting is I rarely see older adults have the insight to say, I think I need to see a geriatrician, right? So that's kind of struck me because they don't even know what a geriatrician is. So yeah, I think going back to what Lucas is saying, and even Dr. Saltman, I would want to revisit, since the death of his wife, I don't know how long ago, he said 10, 15 years, right? And that seems to be around the same time he says he stopped drinking, but he's making the rounds to the ABC store. A lot of veterans, that's a convenience store. So his perception of how much he's drinking now may not be as much as he was drinking then. And yeah, Dr. Saltman's right in that, he may probably be minimizing how much he's drinking or self-medicating to deal with loneliness, depression. But here's an engineer. I rarely see people going out, engineers seeking out to have social conversations with people. So maybe he is lonely.
Yeah, he definitely struck me as odd. Too. Yeah, they are.
But Sarah reminded me of something here that is important, and that is, somebody prescribed him meclizine. He's getting a lot of medicines. There's a lot of, he's on tamsulosin or something you said for his BPH. He's on a lot of high risk medicine for falls and for dizziness. He's got his AFib with the rapid ventricular response. You would want to revisit that to be sure that it's not really coming. He might be a candidate. I don't know how. What everybody else said is absolutely right. You got to sort of judge whether he's interested in medical intervention and sort of medical evaluation or not, and that's going to help or not, and what his expected longevity is. Those are all factors into that. But a medical workup would include, I think, that MRI, looking for central explanations for it, and it might include a 24-hour or 48-hour cardiac monitoring to see if that rapid ventricular response is correlates with the times of his dizziness sort of idea, because that could be another explanation for it that has nothing to do with any of that other stuff.
Yeah,
right. So quick summary, I started with the neurologic workup, and I was trying to get his cardiac records, and definitely blood work, looking at thiamine, B12, and all of the nutritional deficiencies. Unfortunately, I won't see him again because I'm now off my VA rotation. So this is one of those where I'm not going to know what happens, but thank you all for letting me present.
No, thank you. This was generated a lot of great discussion points, and it was brought a lot of good things to remind ourselves of. People take note, there is an evaluation in the chat box. Please click on that and fill out the evaluation to get your CMEs. and want to welcome people back, invite people to next month's session. And we will have our other second-year fellow, Susan Christensen, presenting at that time. So that will be looking forward to that. And going forward, we're going to have Dr. Rita Bell Fernandez taking on the leadership role of this ECHO series. So that will be exciting too. So I just wanted to have her say hi to everybody. And thank you very much. I'm going to pass the baton to her. And yeah, and let's just keep on encouraging each other and inviting people to join, and we can all keep on learning together. Thanks, everybody.
Thank you all.
Thanks again.